everyone. Welcome to today's peer sharing and learning session. Today, we'll continue to talk about team-based primary care with a focus on role definitions and working to scope of practice. As we wait, we're going to give everyone a few minutes to sign in on their lunch break. We just ask that you introduce yourself, your OHT or organization or PCN in the chat box. For those of you I haven't had the opportunity to meet yet, my name is Leslie McGeough, and I'm a focal point and coach with RISE, supporting population health management and primary care. While we wait, I'm also going to just remind you of the OHT shared space. This is a place where we will post recordings from sessions like this and many other resources. And it's also a place where you can exchange conversations and questions and resources with your peers between these sessions. Thank you, Steve, for putting it in the chat box. I also want to call out that we have some new resources available for you. These are posted on our RISE website. They're also posted in that OHT PCN shared space that Steve just kindly put in the chat box. And thank you for putting the peer profiles in the chat box as well, Steve. Just a reminder that today's session is being recorded. For those of you who have historically joined us, we've only posted it in the OHT shared space, but the last few months we have opened it up to a broader audience. So today's session will be posted on our website as well. All right, it looks like we've got a good number of people joining. As you continue to join, please continue to introduce yourselves in the chat box. But we're going to kick off today's session to leave lots of time for our presenters today and for all of you to have good discussion and questions and answers. So I'm going to pass it over to my colleague at the Northern Ontario School of Medicine, Jin Fan Huang. And Jin Fan, we're getting a bit of an echo, so just everyone to go on to mute.
Okay, can everyone hear me?
Yes.
Yes. Good afternoon, everyone. Thank you for sharing your lunch hour with us. My name is Jin Fan, and it's always a great pleasure to deliver the land acknowledgement. I acknowledge that my home in Toronto is located on the traditional territory of many Indigenous nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Huron-Wendat people. And Toronto is covered by Treaty 13. I also acknowledge that my place of work, Northam University, respectfully recognize that our Pan-Northern campus is on the homelands of First Nations and Métis people. The university buildings in Greater Sudbury and Thunder Bay are located on the territory of Anishinaabe Nation, specifically the Anti-Commission Anishinaabe, Wanapate First Nation, and Fort William First Nations. As someone who comes from Asian ancestry and a young researcher working in the healthcare system, I always feel very grateful to live and learn on these lands, recognizing that I am a guest here and carrying a responsibility to approach my work with respect, humility, and ongoing commitment to truth and reconciliation, including listening, learning, supporting Indigenous health, sovereignty, and self-determined priorities in meaningful and accountable ways. Thank you.
Thank you, Jin Fan. And I believe now I'm passing it over to our head coach, Mike Hindmarsh, to kick off today's session.
Hi, everyone. For those of you in Southern Ontario, welcome to 2 feet of snow and still coming down. Today's agenda, what we're going to be looking at are the objectives are to gain an understanding of what are the primary drivers that for building high-performing primary care teams. We're going to see some examples of efficient team-based care, what it looks like to really be a team versus a group of people that are inside a building. Look at some issues of scope of practice and how we build trust in teams. And then, of course, as we always do in our sessions, we'll have a discussion at the end where you can ask questions of the presenters or talk about what it is you're currently doing to share with other teams that are just beginning this work. These are the objectives. They're pretty much the same, so we can skip over that. Um, I always begin with this slide. This has been the work that we've been doing for 6 years. We're going from the chaotic system of care on the left to a more integrated, accountable system with high-performing primary care at the center serving their patients. And as I've always mentioned, it's never too late to get this tattooed on the back of your youngest child's back, so you never forget it. So, next slide. The other thing too about this work, and I know that it seems that we've got lots of different work that we have to do, but this may seem like why are we building primary care teams at this point? All of the work you've been doing for 6 years has been leading to this, to building high-performing primary care at the center of your accountable, integrated organization. It helps you meet your TPA requirements and number of your measurement requirements for OH in the ministry. And so we just want to point out that this isn't new work. This is sort of the culmination of all the work you've been doing for the last 6 years. Next slide. At the last session, we showed you this driver diagram of what it means to create a high-performing primary care system that is continuous, collaborative, equitable, accessible. And in that first column under primary drivers, last week we focused on team-based care. We're going to be doing that again this week. So let's go to the next slide. If we blow up team-based care and make it the aim, that is building effective primary care teams, then there are primary drivers that are involved in that. There's secondary drivers, there's change ideas. Don't worry about reading this. This is an example of a driver diagram of all the different change ideas and drivers that create effective primary care teams. And in today's session, if we go to the next slide, we'll be touching on a number of the primary drivers and the secondary drivers that are associated with those, as well as some of the change ideas. As we move forward, RISE will support the OHTs in understanding how to use these driver diagrams with their primary care practices in their OHTs and also assist the PCNs to understand how to use these to build more effective teams in their OHTs in their geographic area. Next slide. And when we talk about team-based care, there's lots of definitions. I pulled this one. AI actually put this together for me, and I rather like it. It's primary team-based care is population-based care is a collaborative model where a multidisciplinary group of health professionals work together to provide comprehensive services to a defined population, panel, or roster in our situation, rather than just focusing on individual episodic visits. The roster includes people who come in for care as well as those that don't. So we obviously have to reach out to them. And the approach integrates traditional patient-centered care with public health style functions to improve outcomes for a specific community or clinical population. So that's one definition, but it gives you the idea that what we're really looking at is how do we bring people together that are already maybe in large practices like family health teams, but how do we make sure they function as a team? And then a big part of our focus today will be for all of those clinicians that are in small group practice and solo practice that will need a lot of support to create teams or teamlets is another way of thinking of them. Let's go to the next slide. When we think of the key components of primary care team, they're multidisciplinary. There are a variety of people that are involved in them. You can see the list there. It's not just necessarily a physician and a nurse and an MOA, but it can be a number of people that are supporting the team. There are defined patient panels. That is, each practice is responsible for a specific population, whether it's a geographic community or otherwise, and they make sure that no one is unattached or falling through the cracks. Chronic disease management is delivered proactively rather than waiting for people to come in the door. So you reach out to those populations using the medical record to build things like registries, exception reports, and make sure that people are getting their appropriate chronic disease management as well as preventive care. And then, of course, there's a focus on equity. We have to make sure that the people that are being cared for, that we understand what social determinants might be affecting their health and how we can make sure they get to community services to address those. Next slide. This is just a visual of who could make up the primary care team. We don't need to spend time on it. I just wanted to emphasize that it can be a large group of people and that they may be in one place or they may be shared across various organizations. Let's go to the next slide. And then I just want to end with, we have a multitude of models of care in Ontario. And I'm not going to go through this slide. What's important to recognize that many of these models have lots of people involved in them that could be shared with smaller group practices or solo practices. And the one large group that is not on this page are all of the solo practices that are currently just fee for service. And they are folks that really need support when it comes to doing team-based care, because in many cases, it may just be a physician or a nurse practitioner working with a front office person. So I'm going to pass it over to Rob Reid. Rob is a physician and leader of our RISE along with John Lavis. Rob has got a extensive history in working in primary care, worked extensively in the US. He and I worked together down there in a large not-for-profit group model or staff model HMO in a research organization, doing work around the patient-centered medical home, chronic disease management. He's come back to Canada and was the director, the leader at the Institute for Better Health. And he is an expert in primary care and building teams. Rob, take it away.
Yeah, thanks, Mike, and so nice to meet everyone. I come periodically to your sessions, and they're always just so good. I want to talk a little bit before we give the floor over to our next presenters, who are really going to talk practically and meaningful about what it's like to work in teams. I want to talk a little bit what we're talking about in teams, what teamwork is in primary care, actually. So, as Mike talked earlier, teams are more than just putting a group of people together. It's more than that. They have to work conjointly in a shared way to deliver care. So they're composed of people with complementary skills working collectively towards the same goals. Okay? They're built on foundations of trust and mutual respect. We have to trust the other team members that we're working with, that they will provide their service in the right way for our patients. And we have to respect all of the roles that people have on a team. Effective team is highly relational, and it's highly interdependent. Working as in a primary care team, team members are very much dependent on each other. And they develop shared knowledge about what each other's does and what all the responsibilities have and the standard work that all the different team members have. So that shared knowledge about everybody's role is really critical. It's more than that, though. Team members often team role blend, and you're going to hear a couple examples of that from our speakers early. They take on tasks filled by other people in different roles to gain efficiency and synergy. So it's not stovepipe, they're working together. To make teams really functional, the essence of this is really good communication. And communication needs to be frequent, timely, accurate, and problem-solving in nature. And that one of the jobs of leaders, of which many of you are leaders in your primary care, PCNs, and so forth, are to create those communication channels. They have to be created and used consistently. And that effective communication facilitates these effective relationships and vice versa. And this is known as relational coordination. The better the communication, the better the relationships. And this is how highly functional teams work. Okay. And you're going to hear, I'm giving you a lot of concepts here, but you're going to have some real discrete examples in a few minutes as to what this means. Okay. Now, what is it that, let's go to the next slide, Leslie. What is it that leaders can do to build effective teams? There's a lot that happen. Teams just don't happen by accident. They're built and nurtured over time by leaders, managers, and coaches. And all of you in your respective OHTs and PCNs are in that role. Key structures are really important for team development, and that is about shared protocols, shared directives, and shared standard work templates. So everybody knows what everybody's role is and how they all fit together. We have to have opportunities to talk to each other. So it's shared meetings, shared huddles, and shared opportunities to reflect, plan, and learn. And you're going to hear several examples about this today. And then finally, we can't have stovepipe information. We have to have information that reaches across our team providers in a shared way. So shared information systems. And then leaders and managers have particular tasks that they have to do to help nurture and facilitate teams. We have to select and train for teamwork, to help people understand how to work within teams. Develop shared accountabilities and performance metrics so that they're not in all individual metrics, but we're actually looking at team metrics. We have to develop shared recognition and reward systems so we recognize and reward teamwork. Teamwork is often hard, so we have to actually figure out when the conflicts occur and how to manage them. So there has to be some ways of conflict resolution. We have to design teams. Often you hear examples of that today about how we have team-based job design, and we have boundary spanner robes so people know exactly and can function across different roles. And then finally, we need one thing that really helps is quality improvement initiatives, so that all team members are there with their particular expertise and their role coming together as a bigger whole. So those are just some examples. We're going to come back to these things in future sessions and really think about how we can build these things in our PCNs, our clinics, and our OHTs. Now I want to give it over to Dr. Roll, who's working as a primary care doctor and has a lot of experience working in very high functioning teams. And he's going to talk a little bit about what his experience is about how everybody works together in a primary care environment to really facilitate this work. So Dr. Roll, can I hand it over to you?
Thank you, Rob.
And Dean, if you don't mind, I'll just introduce you so that people. So Dr. Dean Roll is a family practice doctor of 35 years plus. He's been a family practice doctor in both the U.S. and Canada, 10 years at the Community Health Center in Rexdale, and most of his career was within high-functioning teams at that not-for-profit HMO that I talked about in Washington State. And what he's going to talk to us about is what that team was like. Go ahead, Dean. Thank you.
Thanks, Mike, and thank you for inviting me to talk today on my experience gleaned over the years and decades. This slide that I created and sort of the title I was given was "A Day in the Life of a Primary Care Team." For me, I always use the term, this is where the rubber of the healthcare system hits the road of care delivery. We've used the term teamlet, and I just sort of want to talk about a teamlet, which was kind of the basic unit of the team, which would be the MD or nurse practitioner and the medical office assistant. We worked closely together in the direct care of patients throughout the day, and this person was the one that I would interact the most frequently with, and their interactions were with most every patient as well. Then there was kind of the clinical team, which was typically a group of about 5 to 7 medical doctors, nurse practitioners, and medical office assistants, and then shared staff such as the RPNs, RNs, pharmacists, physical therapists, clinical counselors, social workers, midwives, and lots more as described on that previous slide. This was typically considered a manageable size for an operational group, in that a typical MD would work 4 days a week. So 5 members was always a great way to ensure that everyday coverage for the week could be even. The sharing of these 5 to 7 MDs and MOAs with the RPN and RN allowed the economy of scale, both for space, exam room utilization, perhaps if a specialized procedure room was desired, and medical supplies, electronic data systems, hardware is much easier as well to share with multiple providers, and definitely personnel. Hard for a single MD to have a full-time RPN or RN on their own. Definitely other coverage issues. Somebody wants vacation or leave. With a team-based care, it's easier to spread the work out amongst everybody. To look at the typical day, and that's sort of what this is, and I kind of just did a very arbitrary 9 to 5, where the clinic would open about a half hour prior to the first patient scheduled in person. And everyone would be in, everyone would be available, start working right away. It was interesting that the medical office assistant had already started the day's work the day before. They would see the schedule, look at it in advance, and they would mine patients' charts. They would go through to see if there were anything that would be needed through the course of the day, in addition to what the patient thought the problem was and their reason for the visit. Everybody, the doctors, nurse practitioners, RNs, everybody was sort of looking at anything that happened from the time from when the office was last open. So any blood test results, electronic messages received from patients, any reports from the urgent cares, emergency departments. We had access to a 24-hour nursing service, so all of this could come in. As we were also well aware, the moment a clinic opens in the day, there's a large number of patients start calling in, and high priority was given to get those calls answered and even resolve them, rather than pushing your work down the road. Is take care of it as it comes in. We had phone systems that were programmed that everyone could sign into the main trunk line for the clinic and take any and all incoming calls, and we were all encouraged to do so. So patient called in, they could get the doctor on the line first thing in the morning, get the problem solved, and their care could be done. We would do that sort of for the first 15, 20 minutes. At 20 minutes, just before the first patient was to be seen, and probably the most important part of the day, that little blue line, a team huddle. Typically within the team, a team leader would be chosen. It could be anyone, and they would call all the members together for a 5 to 10 minute huddle to discuss sort of the day ahead, to sort of they've looked at their schedules, what's happening for the day, what resources do they need, both maybe in room needs, equipment needs, personnel needs. Perhaps a diabetic patient was coming in with a specific concern and could use a bit of contact from the certified diabetes educator. This was sort of all looked at, and all the MDs, nurse practitioners, would sort of contribute. And again, sort of any potential conflicts, two people needing a room or resource at the same time, could be managed before patients got in. We also typically had tracking boards, and we would monitor our practice metrics. We had access metrics, patient satisfaction metrics. Mike talked about patient care exception reports. We called them peakers, and it was just looking at care that a patient should be getting that hadn't been delivered or recorded yet, and sort of looking at examples where we could improve and add to the patient's care. We would also typically sort of review sort of any lessons learned, give some kudos out for the previous day's work, and build some positive reinforcement for the team building. And then we would get to the direct patient care. I guess I should have put sort of some more dots in there, those sort of pinkish dots. A little bit of time, we realized a day is not totally set in stone. So having a few openings for same day access was always part for everybody through this. The teamlet of the MD and or nurse practitioner and the medical office assistant then sort of participated in direct patient care. In morning afternoons, typically the same thing, where the MOA who had done the previous pre-visit work checked to see, were labs available, was some screening done, or any other chronic disease preventive tasks needed. They would set the patient up for the visit, do vitals, get them ready if perhaps anything was needed, and then allow the doctor to come in and do their work of direct patient care, which is sort of the part that we all kind of know about. While the doctor was doing his thing, the medical office assistant was then working on the next patient and kind of continuing the stream to utilize the physician's time most appropriately. to get as many patients in. The additional roles, and again, these other members were kind of the ones that I had at most commonly when I was working at group health, but at the community health center, some of them were different. Kind of weaved in and out. Sometimes, as I was conducting a visit, needed some support from an RPN that I could grab. Sometimes they could need some support in a patient care or interaction, and they could come grab me, and we could sort of help and through the day. Lunches, I just sort of put that in there. Typically, times were staggered to keep the utilization of all services and resources going well. So lunches were staggered. So again, there were always people on the phones. There were always people ready to help patients as they could come in through the daytime. Afternoon session, typically a small mini huddle was again done. Again, just sort of looking, things probably have changed from the morning to now. So a small teamlet meeting just between the MD, nurse practitioner, and the medical office assistant, just to make sure everything could be gone through for the rest of the day smoothly. At the end of the day, the medical office assistant was already starting to get ready for the next day, had been looking at the schedule, again, mining those charts, looking for golden opportunities of care for the patient. The doctor would be finishing his care of the patients, answering any final messages, maybe making a couple of final phone calls and reviewing any additional lab reports and patient information. I always found at the end of the day, it was just a really good time as people left, saying goodnight to them, but thanking them for the day, again, building their sense of purpose and helping and thanking them for helping me in my purpose. I also think the final thing was the phones were forwarded to the 24-hour nursing service, and the doors were closed to the clinic. Again, the next day to start with preparations already going. Next slide. This one I kind of did just to kind of give the example of the patient's journey, in that, you know, the whole reason why this team is here is to help the patient, and this is the lifetime of their care. Happy times, challenging times, boring times, and ongoing times. I kind of just put numbers for the different sort of events. And event one is the attachment to the system, which kind of likened to a first date. It's starting the relationship between the patient and the members of the healthcare team. It's information gathering, demographics, medical and social determinants of health needs. And this can be done through online resources and questionnaires, medical office assistants, clinical counselors, or the RPN, RN, nurse practitioner, MD. Typically, anyone can do this. And again, practicing to top of scope really sort of helps and as many people to do this service as possible. It would be to get identifying the current health needs and getting people up to date. And then where this line then sort of thickens into the cylinder, this is sort of the three-dimensional, the team is surrounding the patient and helping them on their journey. Two major health conditions occur along the way, and this is where often the medical doctor, nurse practitioner, RN are connecting with the patient, getting them the care they need, coordinating the care they need, and getting them connected to all the services that they need. Three, it's kind of, I sort of wrote this as nothing in the patient's life. They don't think there's any issue, but the team is still there and they are looking at this. And this is where online resources, medical office assistants, MAs, this is the outreach. This is, hey, we haven't seen you in a year, and we see that it's time for vaccine. We see that it's time to follow up on well child care or chronic disease monitoring, or you're on chronic medications and they need follow-up, frailty for seniors. It's just sort of, hey, we are here in regular context to make sure that nothing has happened that we aren't aware of. In that we are patient-centered, but also family and community-centered. We sometimes are taking care of those around the individual patient. And this is where counseling, RNs, MDs, everybody, again, as needed, can get involved. Primary care is sort of the coordinator of all of these services and making sure that we are aware of their need as well as that they are provision. This one I put in of minor care issues. This one I just sort of put in there in that there has been development, or this is a developing issue in Ontario, as scope of practice has changed, and things now of a team pharmacist or a registered nurse can provide much more service and allowing me to focus more on my particular expertise. I think I better kind of keep moving here. And so in my final moment, just kind of wanted to say that this provision of team-based care gave great professional satisfaction. I could use my skills in the most efficient way and do the things that sort of I had the training for, specifically in primary care, and helped in mentorship to other members on the team. Definitely patients totally much more happy from the experience. They appreciated that all members of the team kind of knew about them, could participate in their care, and liked the concept of more brains involved in their care. It was a good feeling. Group health would monitor regularly patient satisfaction surveys, and definitely everyone would see a very distinct increase. Myself and other team members also had very much more or higher job and organizational satisfaction. We were providing care to others, but we were also helping out each other. And I think that was one of the best things. And I've moved away 10 years ago, and I'm still totally connected to many of the members of the team that I was with back then. And as well, patient or staff satisfaction surveys also were done. And those metrics improved greatly as well. To use the term of physician burnout, it was definitely shown to be beneficial. And then I was sort of thinking again, because I'm talking about the day in the life, I could go home at the end of the day knowing the work for the day was done, and that there was already a good start on tomorrow, and I could return to work with the team to face new challenges. Great, thank you. Questions later, yes.
Wonderful. Thanks so much, Dean. Our next two speakers bring an interesting perspective on team-based care. Our first speaker, they'll actually speak together, Kirsty Barrett, is a Franco-Ontarian, a registered midwife and researcher at the Northern Ontario School of Medicine, which partners with RISE on a lot of the work that we do. She's worked and lived around the globe and now finds herself in Thunder Bay, which is built on the traditional territory of the Anishinaabe, which includes the Ojibwe of Fort William First Nation, signatory to the Robinson Superior Treaty of 1850. Co-presenting with her is Jenny Huntley, who is also a registered midwife in the Northwest Community Health Centers in Thunder Bay. And she's worked as a midwife in Quebec and Texas. Texas, that's fascinating, Jenny. We'll have to talk sometime. As well as Ontario and in Haiti. Her particular research interests are on perinatal substance use and program evaluation and midwifery models of care. So Kirsty and Jenny, take it away.
Thanks, Mike. Thanks, everyone. Can I just say I really enjoyed Rob, Dean. That was great. I just really loved hearing the sort of nitty-gritty of the day-to-day and what that looks like, and can certainly attest to your positive feedback, having worked in that environment before in terms of job satisfaction. So Jenny and I today are going to speak a little bit about midwifery, but mostly in terms of the role of the midwife in a team-based care. And I'm going to use your term, Rob, because I had to write it down, but you talked about boundary spanning. And this is really the message I think that many teams around the province are getting, and hence working with midwives in terms of boundary spanning in midwifery care, and how that can really optimize the team working together and providing care to your communities. So I only wanted to put this slide in because I assume that maybe not all of you understand how actually well integrated midwives are in Ontario, the number of midwives, and also the places that we work, understanding that we have many midwives working across different settings, certainly growing within interprofessional team care. And that can be in CHCs, family health teams, and other not-for-profits. We also have many Indigenous midwifery programs that are serving First Nations communities, and more often than not, those are interprofessional care teams. So we'll go to the next slide, Mike, or Leslie, somebody. So again, this is just a snapshot of midwives in IPCTs. And the drivers for success for us to optimizing, midwifery roles in teams have to do with integrating midwives in the early phase. So when you're looking at building interprofessional care teams from whatever position you're in, if you're already preempting who might be in your team, is to integrating those providers early, or collaborators that represent those providers early enough. And Jenny will talk to their role, as they were actually the first midwife to come in and integrate. And the program at CHC Norwest, actually, before it even started, midwives were involved in that planning. So we're going to talk a little bit more about what it means to work at full scope. And I think what we're saying about scope and spanning scope can be applied to any healthcare profession that's regulated in Ontario. Obviously, removal of unnecessary barriers or restrictions, which I think when you're looking at optimizing team-based care, implementing the principles of optimizing team-based care removes barriers and restrictions for all of us, right? And then we're just obviously looking at adequate remuneration. And again, midwives' involvement in the decision-making of the team. So again, if we're optimizing that team communication and better relationships and trust building, then that optimizes the involvement of all registered practitioners and midwives in this case. We can go to the next slide. So I loved this so much, and Rob put it up, that I thought I would put it up again and just talk about how relational it is, the work that we all do. It's very highly interdependent. The first, to me, in my mind's eye, the knowledge of each other's roles and responsibilities is really important, and that includes the knowledge, like having leadership understand the roles and responsibilities. So managers, if you have clinic managers, if you have executive directors, having them understanding the roles and responsibilities of providers that they might not have come across is quite important. Having key structures, which we're going to get into specifically around medical directives, help with that shared understanding. So I think we can go to the next slide, and I'm going to get a little bit more into what I mean. So determining and designing role structuring in a team means understanding what people do. I think that's probably like the easiest way to put it. And often we hear it the most often is, I don't know what X provider does. What do we mean by that? We actually mean what is within their scope of practice. Scope of practice is authorized decisions and procedures. We have the Regulated Health Professions Act. If you're ever feeling daring and adventurous, you can go online and it's available to you in its entirety with all the regulated health professions and all of their scopes. However, I just did want to mention that because each regulated profession has a governing body, you can often go to those governing bodies and get that information directly for yourself. So if you really are feeling like you don't know what a profession does, it's just a good first starting point. Also talking with that provider about their scope of practice. Now, I wanted to mention medical directives as a way of boundary spanning, but I also just wanted to mention that often we hear this working into full scope of practice, and acknowledge that sometimes we are not at that boundary spanning, and we are not taking full advantage of our teams. And I think, the way, Dean, you describe that day-to-day communication and learning, like we are learning what is within the boundaries of our teams, and that constant communication and rechecking in is really, really important. the medical directives is a tool that if as a team, and Jenny's going to give the more specific examples about how that works in their environment. But if you are looking at your team and you are feeling that the team has the skill set and the education, but doesn't necessarily have the regulated capacity to do that, like within the boundaries of our governance structures, you can create an alternative structure that is called a medical directive. And I also wanted to point out that often medical directives are predicting what's going to happen in the future with a profession. Not predicting so much, but it's taking into account of a way a profession might be expanding. And a really clear example of that with midwifery is that we knew and we were pushing and working with legislation to increase our capacity to administer IUDs, for example, and to take a much more active role in abortion or first trimester loss. We knew that's what we were pushing with the government, but the government moves how the government moves. It's a regulated Health Professions Act after all. And so medical directives were a way for us to start practicing. And a lot of times, and what's happening is what we were doing in medical directives is actually now going to become within our scope of practice. So I also wanted to point out, and this is the same with many professions, is that it also is sort of a way that a profession can evolve. So I just have some information here that I took from HIROC, which is the Health Insurance Reciprocal of Canada. As I wanted you to recognize that there is a resource for you if you are thinking about medical directives and you're not sure where to start. They are a very good resource in terms of the medical legal language around medical directives, and also just providing some really good guidance, especially for primary care providers who often we hear concerns around medical legal liability. When a medical directive is done transparently and well, it mitigates those issues quite nicely. So this is just some information about medical directives and again, some resources for anyone here. I'm going to move to the next slide and then I'm going to segue over to Jenny to talk about their experience optimizing patient and client care at Northwest CHC. Are you there, Jenny?
Okay.
Yeah, there you are.
Thank you, Kirsty. So I'm a registered midwife. I've been at Norwest Community Health Center since 2020 in Thunder Bay in northwestern Ontario. And I started here at the time when midwifery models of care in Ontario were slowly being expanded to include interprofessional care teams and interprofessional care settings. And so that's just really been for registered midwives, um, since about 2016, 2017. And so the proposal initially for the program here was to address community needs for certain populations that just had not been accessing either prenatal care or other types of care that midwives can provide. And so initially, the proposal was for several midwives to be added to the community health center setting where we already had many years, decades, in fact, of interprofessional care with MDs, RNs, RPNs, nurse practitioners, and community service staff, people providing community health related and outreach, as similar to what was described in the previous presenters. And so our role as midwives was to provide services that were particularly within our area of expertise and to address these community needs. And so when I joined the team, I was the full-time midwife with community support from midwives who were providing other services in the region. And I realized very quickly that we needed some support. In fact, I joined Norwest 2 months before the COVID-19 pandemic was declared. And so part of my initial work was to assess community needs for primary care and preventive care, and to create a Well Baby program for immunization, preventive immunizations, and other programs for those families that weren't able to access primary care options and preventive care options. So what I've found initially was that the interprofessional um, care team, it really required both on my part and the part of the CHC to um, orient ourselves to each other. So there was a lot of curiosity and openness from all of my team members, as well as some existing familiarity with midwifery, which I think really facilitated my integration. And then subsequently, we've been able to hire more midwives into the role. So familiarity, curiosity about what we could offer clients, and then increasing the roles that we could play in collaboration with our MD and NP and RPN colleagues, and expanding the availability of services at the CHC. I just want to say that we had invitations regularly to present at clinical rounds. And so I think that clinical case reviews and clinical rounds in a team-based care setting is invaluable, especially when we could pull in speakers from other midwives from other interprofessional care models across the province to explain some of what they had been doing even before we were. It really increased people's comfort levels around the interprofessional models and the medical directive that we were using and that we were hoping to implement. So.
Can we go? Thanks. I was just going to say, let's go to the next slide. So we pulled up this slide to show you specifically the difference between, this is Jenny's role and the midwife's role, and how there are activities or tasks that fit within the scope of practice, but how the medical directive allowed for that boundary spanning. Jenny, I don't know if you want to talk to this for a minute, and how you also got how you decided together as a team to get these medical directives together, and what did it look like?
So the process it was very much a community needs assessment of informally both what providers my fellow providers at the center were not able to, or not just didn't have the skills and training to take on these services. So we definitely focused on areas that were not already being offered in the team at the CHC, and then also broader community needs based on community organizations coming to us to say, hey, can midwives do this? Are midwives able to do this? We were really inspired by other teams in other settings, like I said, and they were really helpful in sharing. So we have communities of practice across Ontario and across the country of midwives and other providers, sexual and reproductive health providers, who are able to talk to each other and compare notes around what would be the most effective boundary spanning of midwifery care, where when we're time limited by our scope of practice, how can we increase the time through the use of medical directives, the time that we're able to provide care to people.
Yeah, and I just wanted to add to that, and I think we're wrapping up, and so I think there's a great question for Dr. Royal in the chat box, but I wanted to actually answer that question as well, because we did take that role. I almost thought, Rob, you were setting us up for that answer, because, for example, at the CHC, midwives are responsible for cancer screening, and more often than not so that person will get a call back for cervical screening, and then will be seen by midwives regardless of age. So within our scope of practice, we can only provide cervical screening for pregnant postpartum people, but within the medical directive at CHC, we can provide cervical screening for anyone. You can be 75 and come to me or a midwife for cervical screening. You can be 15. Well, that wouldn't be appropriate for cervical screening, but for STI treatment, for example. So that's just a little teaser, and I'm really curious to see how Dean, how you respond. But I think that's it for us. Hey, Jenny, unless you had any. Okay.
Yeah. So, Dean, I don't know if you can see the question in the chat box, but I'll read it for those that maybe don't see the chat. Rob has asked Dr. Roll. He said, you mentioned that it was everyone on the team's responsibility to get patients what they need, like cancer screening or chronic illness. Could you describe a bit what you meant here? What did other team members like pharmacists do in this regard?
Yes, great. And actually, kind of part of the answer there was already given by Kirsty. I would just describe it as, and some of it is EMR based. When a patient chart would open in Epic, often a little box would appear right in the center saying vaccine due. It did not matter who opened the chart. If you had the medical capacity to open a chart, so even if you were a receptionist, you open the chart to make an appointment, you saw that and it's like, yeah, you're coming in for your cold, but it also says you need a vaccine, or hey, you're also due for that. So any member of the team who's touching that patient is providing full care for that patient in that direction. And again, that's not out of scope. That I don't even think needs a medical directive. It is just saying, hey, you need to check in with somebody who can make sure that this care is provided for you.
Great.
And yeah, the team pharmacist, the physical therapist could say, get in for your vaccine as well, or get a vaccine done when you're here for your knee physiotherapy. We're all there.
Terrific. Makes good sense. Just before I ask Colleen to come off and ask her question in person, I just want to point out what Dr. Brianne Wood said, that high functioning teams can increase access to primary care. And I think when we think about attachment and the work that's being done around attachment, one of the things that can be sacrificed is access to care if too many people are attached to a particular panel. So having high functioning teams increases access in a variety of different ways. Colleen, great to see you.
Nice
Go
to
ahead
see
and
you.
ask your
Thank you
question.
for the warning so I can get my earphones in. This has been a great presentation. Thank you so much. I had just put in, because I know some of the OHTs are working on heart failure and COPD. So I wondered if Dr. Rohal could just describe how you're using the team for those more complex or chronic patients, so that it's not only just the physician, say, doing things.
Sure, and kind of actually, I'll say relating back to Mike a little bit in the concerns about access being reduced, kind of with that patient care slide, is if there's an acute episode of care needed, it doesn't matter who makes the first outreach to the patient kind of thing. It could be the MD, it can be the nurse practitioner, it could be the RPN or RN. Again, it is then practicing to the limits of your scope and then moving on, whether it's through a medical directive or just direct transfer of care. For conditions, for chronic disease management, whether diabetes, COPD, I must say, I think I left group health at about the time that they were really working on the COPD, but congestive heart failure, outreach from the RNs and RPNs was a huge portion of that care. Patients could be providing all the information on their progress, weekly weights, blood pressure readings, medication, the pharmacist helping out. Again, so a lot of the care is really the medical plan might be set by the cardiologist who's coordinated with us, but we are then making sure that many members of the team are all providing the service. Again, anything that's deviating along the way, any concerns, questions, yes, get to the MD, but other team members are totally working to take care of the patients and enjoying the heck out of it.
If I can just add from the non-MD perspective, and Jenny, feel free to jump in. But what it looks like is that, let's just say someone does come to see me, or sometimes we would have someone come through the walk-in. A nurse or nurse practitioner might flag that person hasn't had cervical screening. And so they come in, if the person is, really not able, and we can see them right away, we get a knock on the door. Like, hi, we have such and such person, can you see? Or vice versa, we might have someone come in for X reason, but realize that they haven't had follow-up around their chronic condition. And so we're running over to another practitioner and literally just, are tapping on the shoulder and saying, so-and-so hasn't been seen for such and such. What do you recommend? What kind of follow-up will you need? So it's the way, again, we're communicating and relating together and tapping each other on the shoulder for various things. And sometimes, especially in our nature of our work, we might be really free and available to see someone who might not come in again and might need something really important and vice versa. I don't know, Jenny, if you had anything, so that's from the other side of things. It's very fluid.
Rob Reed has another question for you, Dean. And Francois, I'm just giving you a heads up. I'd love it if you could come off camera and ask your question after Rob asks his. Dean, Rob has said you mentioned the key role of the medical office assistant that is part of almost every office, including solo doctors. So are you saying that solo docs already have a small team, even if it's simply an assistant? Are the roles of the medical office assistant different in Canada than what you've seen in the US?
I'll kind of say, and actually, to kind of differentiate between roles and scope. Yes, I would just the scope of practice for a medical office assistant, typically in the United States, was called a medical assistant, is pretty much the same. However, the roles, what they actually get asked to do, is quite different. When I was sort of preparing for this and looking at some of the guidelines about what are the limits of various roles, and sort of knowing, and various scopes, and knowing what I've experienced in Canada. In Canada, I kind of found the medical office assistant answers the phone at the front, did a lot of photocopying and took forms, and they did not participate very much at all in patient care, whereas the scope of a medical office assistant does include things more sort of directly. They can do the vitals, to put a patient in the room and get them ready for the doctor, which can take, a few minutes for every patient. If somebody else is doing it, that's more patients you can get to the provider during the course of the day. So it's kind of the scope versus the role. It's kind of the scope is the same, but underutilized in Canada.
Yeah. And if I can add to that, what I've seen in practices in Canada and the US is quite often the medical office assistant can do screenings. So they can administer the PHQ-9, let's say, for screening for depression, and score that and have it ready for the physician when he or she comes into the exam room. So screenings, gathering information on social determinants of health, these are all things that the medical office assistant can be involved in. Francois, go ahead.
Thanks for the presentation. Regarding medical directive, maybe it's my understanding that's not correct, but from what I understand, a medical directive falls legally under a family physician or a nurse practitioner, and usually, I think the ones I've been involved in, they're services that the physician is already comfortable with, and then you're kind of helping offload some of those services. What has been presented by the midwife is, sorry, I forget your name, is expanding on services that the MD would not be comfortable with, which I found very interesting. But can you comment on trust or issues or something or in that nature that could arise from doing this in this way, or is that just a common practice and I'm just not aware of? Thanks.
Did you want to start, Kirsty, or I can definitely, and I'll kind of say, though creation of medical directives is a bit out of my scope and pay grade, but I'll kind of say most medical directives are established within groups. Again, kind of the scope versus role. family doctors have a scope of practice that they can do. They then choose their roles, and their roles get chosen for them. As an older male, my practice has changed. I don't see the 25-year-old females anymore who are needing midwifery type care. So again, that's where understanding what the scope is of somebody like a midwife, and kind of saying, hey, you can do this and it's within your scope. I can do things that are within my scope. And together our scope is expanded. Again, boundary spanning. We are creating a wider screen. Kirsty, I'll let you add.
Jenny, I see that you.
Yeah.
Oh, yeah. Do you want to comment, Jenny?
Thank you, Mike. Yes, I appreciate the clarification. What we've seen at our community health center is that we definitely are working under medical directives that are established within the scope of practice of the MDs and the NPs. We're not doing acts. Obviously, we're not delegated acts that are outside of their scope of practice. However, they may be things that the physician or the NP learned in their training but haven't used on a regular basis, and so they feel competent to do them, but they aren't necessarily the best people to be doing them every day, or they don't have the space with all the chronic care management that they're doing to focus on those, on really being the best person to do those, provide those skills. And so what we found is that for people who physicians that are delegating to us, or NPs who are delegating to us, who are not using those skills every day, we work collaboratively to establish a medical directive that feels very comfortable for all the team members, and that has, and we get input from other providers outside of our center in order to make sure that everyone is feeling good with the clinical direction that we're taking around expanding the scope. And the medical directives that we've implemented are almost all extensions of the midwifery scope of practice, but increasing the time that we're able to provide care to people in terms of the lifespan. So prior to pregnancy, after pregnancy, for people who have never been pregnant.
Angela, Rob, sorry. I'm just going to call on Angela first. She's got a great question. Do you want to ask it, Angela, or would you like me to? Sounds like maybe she wants me to. So she said, beyond knowledge of each other's roles and scope of practice, can you say anything about the group culture or mindset that you found to be conducive to collaborative team-based relationships? Who wants to take that one on?
I'll start. When Group Health initially started doing this back, it was 2003, 2004. I'll kind of say, trust me, there were lots of meetings. There were team building exercises, sort of brainstorming, kind of looking at mission and vision statements kind of thing, and really sort of determining if people kind of agreed in that, and sort of if we're going to work as a team, if all of these people here together in this room are going to work as a team, do we all agree with what we are, where we are going to take this? And it was a lot of communication. There were we would have sessions of team building exercises to help do it. And actually a major focus going back to is sort of the teamlet. Those two people working the closest together kind of really had to understand each other and kind of be able to help out each other. But yeah, it was kind of say great fun and very informative, both about myself kind of and how I understood working together in a team. I've kind of used with you before, Mike, about like sports analogies, and for whatever, whether it's the pitcher in baseball, the quarterback in football, the goalie, it's understanding everybody has a role and working to the best of that role, knowing that you do something that they can't do, but they also do something that you can't.
Great, thanks, Dean. Rob, go ahead.
Dean, you've done just this tremendous job of talking about what a day in the life of a team member is and how you complement each other in working one-on-one with individual patients. And I think you've really opened the eyes up to many people as to what the possible could be in Ontario, compared to where we are presently in many respects. Could you talk a little bit about the relationships you had with other physicians or nurse practitioners? You mentioned that you were a team with them as well, and that's not an individual day-to-day care. What did it mean to being a team member with other doctors or other nurse practitioners that were doing similar things that you were doing?
I guess thanks, Rob. And I guess I would say some of that again goes back to my role versus scope, in that we all had the same scope. However, our demographics, and actually, I think this is kind of leads to Emily's question a little bit about multidisciplinary teams. Our demographics informed the care that we could provide as well. So, sometimes patient requests for providers would dictate the provider best able to help them. I guess the key again is, as you're building the team, and it isn't just the MD or nurse practitioner with the MOA, it is with the other physicians, their MOAs, and all the other members of the team that are sort of shared amongst them all. Again, it is working together to understand what we all can do best. Again, I sort of worked with a colleague who provided most of the HIV care at the clinic we had. Another provider, actually, who was primary care but also had extra training in sports medicine, would tend to see more of the sort of orthopedic type thing. So it's understanding our skill sets. I tended to see a lot of the patients with chronic diseases, specifically diabetes, because of my skill set kind of thing. So we all kind of had our roles within the entire scope of practice. And sorry, and I guess, though I'm only saying MDs there, most of the nurse practitioners, and in the States, they also had physician assistants, were pretty independent in terms of we all sort of had full scope that we could sort of be practicing under, and sort of tended to have our own rostered panels of patients to provide care to.
Kirsty and/or Jenny, would you also comment on the mindset question? What is the kind of mindset that results in collaborative team-based care?
I think I mentioned curiosity about what each other's interests are, what other members of the team, really speaking to what Dean was saying around what people are really valuing, and what is around what is their particular interests. I think some of the NPs here have, like, just for one example, have taken an interest in steroid injections for arthritis or other similar symptoms. And so those NPs have gotten particular training and are able to offer that skill set to any patient who comes in who's requiring those services. And so just being curious and about what other people's skill sets are, or their particular clinical interests, and using the team to provide just a more expanded model. And I would say flexibility. The more we've been able to, at the community health center level, the more we've been able to integrate some level of same day or kind of an on-call type model, the more valuable it has been for patients in terms of the feedback that we get. So if there's any room to provide those, particular for our populations, to provide those same day appointments, the walk-in transferring to a full-time provider, that back and forth and flexibility around who people are seeing and how many people they're seeing when they come to the center, I think has been just really improved patient care and improved our like workplace satisfaction and job satisfaction.
Great. Thanks, Jenny. Before I go to Emily's question, and Emily and Colleen has a follow-up question, I do want to say that when you're building teams like this, and it struck me, Jenny, that just sitting down with the team and saying right off the bat, what would people like to be doing on a daily basis is a great way to start building team. There are always going to be trust issues. For those of you that are familiar with Everett Rogers, this kind of building this kind of innovative, high-performing team will follow a bell curve over time. You'll have people on the left that are ready to do this work, want to try doing it, and we need to harness them, people like Dean and Jenny and Kirsty, to then talk to the larger part of the bell curve that is a little more cautious and not sure that they want to do this work. It's not something that happens naturally. We have to work from the OHG and PCN perspective. We really have to work to spread this. And so you have to have the what's in it for me messages. You know, what is going to make a clinician's life better by getting involved in this, what might be perceived as extra work at first, but actually it creates more efficient teams and less work for everyone. Emily, let's see, you, I think you asked a couple of questions, didn't you? Or are you there, Emily? Or do you want me to ask a question?
I'm here. Dean spoke a little bit about this. So similar to having diverse multidisciplinary teams, I'd be interested to hear thoughts about the importance of building teams from an equity, inclusion, diversity, and anti-racism approach or principles.
Kirsty?
That's a good question. That's a really, really great question. I'm thinking right away about the importance of that value at a leadership level, but as much for the provider level as well, right? So just how Jenny was mentioning how we have to maintain curiosity and be open to evolving, we have to think about the way that we're recruiting and also why, you know, who is on our team. And that also reflects how we're able to provide that care to clients. So I think especially, I mean, acknowledging that, you know, Northwestern Ontario does have limited resources. It doesn't mean that we're not asking those questions. For example, I'll just, you know, say right off the bat, do we have providers that are Indigenous, that represent our Indigenous populations? And if not, why not? You know, and I think the CHC at Norwest has been good at that level, and the midwifery team has been good at that level to ask those questions and to really drive leadership to advance that. You know, Jenny, you've done a lot of work around also training people around inclusivity and gender affirming care, and that has been a big need and request. And I don't know if you wanted to talk about it in that sense, just to answer Emily's question too, or.
I think again, this goes back to the curiosity and the piece about being also expanding our curiosity to our community needs and being really relating it back to what are our community needs and is our team really addressing those in all of the aspects of the work that we do, and how could the team be working in a different way to address a broader community, a broader definition of community. And so both reflective providers that reflect the communities that we're serving, and providers that are also seeking out additional training in these areas to really provide that community specific care.
Rob, go ahead.
Just to echo Jenny, you're making such a really important point here. Is, you know, and similarly, Emily, you know, really a real contemplation of equity, inclusion, diversity, and anti-racism as we build teams and as we promote teams, and the functioning is really purposeful and it can't be neglected, as Kirsty and Jenny is saying. but also maximizing the potential of everybody on the team, as Jenny was saying, because we do care for people from many different groups, in many ethnicities, in many groups, and understanding that knowledge from anybody on the team can really make that team much more functional. So it has both an importance for the people as part of the team, but also a critical importance around the needs of the patient population that you're serving. So great question and great discussion on this one.
Great. I want to mention something that Francois asked Dean about, and let me just pull it up here. He said, to piggyback on his previous question, would you include specialists as part of your team? Should they be as part of our OHT? Dean gave a thumbs up. I said absolutely. I think I'll just make an editorial comment here. In my many, many years of working in primary care and building primary care teams, specialists are invisible. It's hard to get them engaged. It might not be on too much difficult on a one-on-one if you have a relationship with specialists, but for the most part, and certainly in the last 5 or 6 years, specialty care has been quite invisible in this process. There have been some OHTs that have had gerontologists work on their frail population, things like that. But I think we have to ask the question, how do we integrate specialists into the team in a way that makes their life better too? I don't know, Dean or anyone else have a comment on that?
I guess, Mike, I would just sort of add, well, I'll kind of give 2 examples. I would sort of add, and from the group health perspective, working at a larger facility, again, it's about economies of scale. It's hard to sort of have as directly involved a specialist if there's only sort of 1 or 2 or even 5. At a clinic, though, with 15 primary care providers, we were able to leverage our resources, having circuit riders from a multitude of different specialties, both surgical and medical. I kind of would describe, yes, they are part of the patient care team, not so much directly in primary care, but again, even they could open a chart, see a vaccine, and get the patient in for that service. They're definitely part of the OHT. That's without question kind of thing, is that, you know, the OHTs, the regional care is going to be, it is all levels of care. So I guess just our talk today is more limited to primary care.
Sure, that makes sense. I do like the circuit riding notion. When I was at Group Health with Rob and Dean, we had a diabetologist, for example, that would do joint visits in primary care with complex patients. So what the primary care got out of it was a better understanding of the guidelines for complex patients. And what the patient obviously got out of it was a specialty consult along with their primary care provider. We don't have a lot of mechanisms to do that in Ontario. That doesn't mean it's out of the question. I think there can be forward-looking approaches to integrate specialists in that sort of approach.
Yeah, just to echo on that, Mike, is that we really want to use them to their full scope of practice. And that's often about really complex patients or complex problems that are not easily managed by a primary care team. And that's where we really need to bring them in a complementary way, not in just we're going to send them out to the patient or to the specialist and they'll send them back at some point. It's actually working with them collaboratively around those complex patients in many respects. And because they provide incredible expertise that no one else can provide. And that's why it's really important. There are some specialties that are much more critical in primary care than other specialties. And it may be worth working around which of those specialties are really critical. Mental health specialties, general internal medicine, geriatricians, and so forth, that are really relevant to the day-to-day work of Dean, that the complexity often revolves around. So just a thought there, Mike.
Yeah, absolutely. That's great. Thanks, Rob. Jenny.
Just to add to that, our program has our midwifery services have really benefited from a close collaborative relationship with our colleagues at the hospital. And so I see our team as extending to our hospital colleagues. So as privileged members of the hospital staff regionally, we do have access to both pediatricians and gynecologists, and we work really closely with a gynecologist to both support the services that we can offer on site here and also provide seamless care back and forth transitions of care. And so it is much more similar to what you're describing around the collaboration around care rather than somebody being transferred from one building to another where they have to be back and forth, and the communication between the medical records, that kind of thing is not as smooth. But I do think that they can and the shared care psychiatry available to the community health centers is also another example of a hospital-based provider that is able to come on site and be in our community health center on a regular basis to provide that seamless collaboration.
I'm just responding. I'm sorry, I was just typing a response. Thank you, Jenny. Thank you. I don't know who Moat KA is, but they said thanks to all the panelists. I wonder if anyone has thoughts on what this means for OHT PCN leadership. What kinds of efforts can be pursued to help facilitate this at the OHT level? I'll just comment that we're going to continue these series on building effective teams. RISE will also be providing support to any OHT or PCN that wants to learn more about this and pilot ideas around with willing primary care teams to show them how to build an effective team so that they could move forward in spreading those types of improvement efforts.
Mike, I think there's one thing that OHTs and PCNs can right now contemplate as we're moving towards building primary care teams. It's really understanding what the resources you currently have in your communities for other parts of the multidisciplinary team. How many large group practices with medical assistants? How many nurses and RPNs work in primary care or in related areas? What are your resources for community health workers and so forth? Because those are the people that we will use in general in terms of bringing the team members and getting an idea about what the resources we currently have in our OHTs and PCNs is probably the first step that we need to do to start building teams in a better way.
Any other questions at this point? So yes, Leslie, let's just look at the last slide, and Rob started to touch on it. We like to leave these sessions with sort of practical things that you can either think about doing or ideas that you can start testing. As I say, we can help you offline, we can help you in continuing sessions. But these were just some questions that we put together in terms of what you can start thinking about or doing to start building effective primary care teams. So maybe for the OHT and the PCN working together, what do you know what your current compositions of primary care teams look like in the OHT, and including the complements of other staff outside of the physician or the NP? How are these different compositions spread across your OHT? Does geography matter? Does geography help? Does it hinder? So on and so forth. Your OH regional leads may have some data to help you understand that, so feel free to reach out to them and see what data they have. How are you thinking about developing teams? Do you have team building events? What are your information systems? How do you communicate with teams? If you were to reach out to, let's say a PCN was to reach out to the primary care providers in the OHT, how would you do that? How would you begin to develop messages for them to get them interested and engaged in building more effective teams? What are the models that you've got to think about here? Many of the OHTs have a lot of solo practices with just the MOA, and that's often a more traditional model for solo practices. But maybe you can think about how do we put 5 of those solo practices together and share an MA, share an RN, and help them deal with larger numbers of patients. Again, there are a variety of different models. How are you thinking about leveraging the skill sets of people on the team, new roles and responsibilities, especially the RNs and the MOAs? We've talked a lot about expanding scope of practice and using medical directives. How can you start thinking about how you might do that in some of the practices that might be willing to try testing some of those ideas like medical directives or scope of practice? How will your existing information systems be optimized to enhance the team's work? I'm currently working with a couple of OHTs on building registries so that they can monitor certain types of clinical populations and see what their outcomes are, and then produce exception reports to make sure that the patients are the patients that are not coming in are first of all be brought in, and then the ones that are in and are missing evidence-based care, they can do catch-up care with those patients. So that's another thing you can think about. And then what specific strategies to enhance team function could you use? Dean talked about daily huddles. They're an incredible mechanism. I had the privilege of watching team huddles in a US version of a community health center, and what they got done in the 10 minutes first thing in the morning made their day run so much more smoothly than just waiting to see what showed up in an exam room. So again, what strategies? The driver diagrams that we presented earlier will help you think about those strategies. And again, we can if you have questions about the driver diagrams or what a particular change concept means, please reach out to Leslie or myself, and we'll be glad to help you in any way we can. Angela, advertisement from Angela. On behalf of the Align team, I'd love to invite those interested to our PCN Leadership and Governance Peer Learning session next Tuesday at noon. Focus of the session on some PCN forming and norming processes. Align is doing great work on governance within the PCNs, and so I urge you to go to that session. I think you'll find it very helpful. Yes, unapologetic advertising. Okay, we should probably wrap up, Leslie? Do you want me to do the... Yeah, go ahead.
We just have a couple reminders. So this is one of the supports we're currently offering at RISE. So these sessions happen on the third Thursday over lunch each month. But we also have a new suite of a series of sessions, which are interactive improvement sessions that we're calling deep dives. So right now they're not formal presentations. It's more candid conversations between just PCNs and OHTs that are wanting to progress their process of attachment work. So those occur on the first Wednesday over lunch each month. And if you're interested in joining, again, you can reach out to myself or Mike if you'd like to join those sessions too. And of course, the one-on-one coaching, Mike and I are available as our Kirsty and team. We've also shared earlier, but this is where we'll post today's recording as well as a number of other resources, is the OHT shared space. And so you can continue the conversation today with your peers in this space. We'll also post today's recording on our website. And then finally, our upcoming session is on February 19th. We're going to continue to talk about primary care teams. And in February, we're actually going to focus on the mechanics of building a team and sharing resources across teams. So we hope you can all join it then. And thank you very much to Jenny, Kirsty, Dean, and Rob, all for sharing their very helpful learnings with us all today, and for all of you for participating in our discussion. So thank you, and we hope to see you next month.